Good morning. The Virginia Hospital and Healthcare Association and the Virginia Department of Health would like to thank you for joining us today for the Ebola virus disease update for Virginia Hospitals webinar. This webinar is intended to provide situational awareness on the Ebola virus disease outbreak in the Democratic Republic of the Congo and information on hospital preparedness. We have a panel of experts who will answer your questions at the end of the presentation. To ask questions during the presentation, please use the chat box feature in the WebEx platform. I'd like to introduce our speaker for today's presentation, Dr. Lillian Peek. Dr. Peek is the state epidemiologist and the director of the Virginia Department of Health's Office of Epidemiology. She has been a public health leader for more than 19 years, including working at the Virginia Department of Health as the director of the Thomas Jefferson Health District, the director of VDH's Office of Family Health Services, and the deputy commissioner for population health. Before becoming Virginia's state epidemiologist, she served as the director of public health at the South Carolina Department of Health and Environmental Control. We are thrilled to have Dr. Peek here with us today to provide an update on the Ebola outbreak in the Democratic Republic of the Congo and hospital preparedness. Dr. Peek?
Good morning. Thank you for joining us for an update on Ebola virus disease in the Democratic Republic of the Congo, or DRC. I will provide an overview of the situation, the public health response, and actions for hospitals to take. Over 2,600 cases of Ebola virus disease have been identified in eastern DRC, making it the second largest Ebola outbreak since the virus was discovered in 1976. The global risk at this time is low. There are currently no confirmed cases of Ebola virus disease outside of DRC. By land area, DRC is the second largest country in Africa. It's 3 times bigger than Texas. The outbreak has been contained to a small portion of the country in the northeast. Only 2 provinces, North Kivu and Ituri, are affected. These provinces, however, are among the most populated in the country, and they border 3 other countries, Rwanda, South Sudan, and Uganda. There is frequent crossover movement for travel and trade, making the risk for transmission in this region very high. The number of cases thus far in the DRC outbreak are an order of magnitude less than the outbreak in Guinea, Liberia, and Sierra Leone between 2014 and 2016. The case fatality rate, however, is 67% compared to 40%. In July, the World Health Organization assessed the risk to the United States as low. There are fewer than 16,000 travelers from DRC to the United States. Extensive screening is being conducted in DRC at over 70 locations, including the Goma Airport. 75 million screenings have been conducted, with 22 cases detected from that screening. There are no direct flights between the DRC and the United States. A Department of Homeland Security review found that 242 people traveled through the Goma Airport with the U.S. as their final destination in 2018. This is an epidemic curve of the outbreak, a visual display of the onset of illness for each case. Within the 2 affected provinces, North Kivu and Ituri, cases have been identified in 26 health zones. The number of reported cases in 1 week peaked in April. About 80 new cases are being reported weekly. There is continued shifting of hotspots. In July, WHO reported that there have been improvements in surveillance and the intensity of virus transmission has been reduced, but there has been geographical extension. The continued seeding of virus into new areas represents a constant risk of further amplification. Currently, Beni is the epicenter of the outbreak. 1 new case in Goma, which is in North Kivu, came from Beni. His diagnosis was confirmed within 1 hour of arrival at a health facility. The public health response took place within 72 hours. Contact tracing was performed and 75 contacts were vaccinated. Co-travelers and family members were quarantined and monitored. This exemplifies the approach to responding to the outbreak. Public health learned many lessons during the Ebola outbreak in West Africa, including the importance of infection control during burials and strategies to engage the community. An experimental vaccine is being administered through a compassionate use protocol. More than 160,000 people have been vaccinated. A ring vaccination strategy is being used for contacts of cases and contacts of contacts. Healthcare workers and frontline workers have also been vaccinated. There are 4 experimental treatments being used through a randomized control trial. A number of factors, however, have impeded the response. In 1996, Tutsi from Rwanda invaded eastern DRC in search of Hutu who fled Rwanda after the genocide ended. This resulted in the First Congo War. From 1998 to 2003, the Second Congo War occurred, which involved multiple African countries. Despite a peace treaty being signed, the conflict in Kivu, Ituri, and Katanga has continued due to ethnic violence between Hutu and Tutsi-aligned forces. Healthcare facilities and healthcare workers have been attacked. There is significant poverty. There is distrust of government, and this has led to delays in detecting cases early and isolating ill persons. A high number of cases continue to be identified in very late stage of illness. In June, 3 cases of Ebola virus disease were identified in Uganda, which was the first transmission outside of DRC during this outbreak. The cases were related and contracted the disease in DRC. No further transmission from these cases was found. Additionally, cases were found in 3 new health zones within the 2 provinces, including the city of Goma. Goma has a population of 2 million within 29 square miles. Because of these developments, 1 year into the outbreak, on July 17th, WHO declared the outbreak a public health emergency of international concern. Although the national, regional, and global risks did not change, they felt it was important to raise awareness and facilitate an international response. Screening at U.S. airports or active monitoring of travelers, as was done in 2014 to 16, is not recommended at this time. Federal agencies are actively monitoring travel patterns associated with the outbreak. This recommendation could change if the risk increases. We were advised, however, to ensure U.S. healthcare workers are aware of the situation and are prepared to identify a case and quickly respond to prevent transmission. The current CDC recommendation for travelers from the U.S. going to an Ebola-affected area is to self-monitor for signs and symptoms for 21 days after departing the affected area. If they develop Ebola-compatible symptoms, they should self-isolate and seek care immediately. They are advised to call ahead to the healthcare facility before arrival to report their recent travel and symptoms. In response to the 2014-16 outbreak in West Africa, a tiered framework for Ebola hospital preparedness was established across the United States, including in Virginia. This system is still in effect. The tiers consist of frontline facilities that are equipped for emergency care, such as EDs, urgent care centers, and critical access hospitals. They are responsible for quickly identifying and isolating patients with possible Ebola. Then there's Ebola assessment hospitals, capable of providing immediate lab evaluation, coordinating Ebola testing, and caring for a patient for up to 5 days. Virginia has 6 assessment facilities. And there are Ebola treatment centers that can care for lab-confirmed patients for the duration of their illness. Virginia has 2. A 4th tier, not shown on this slide, are the regional Ebola and other special pathogen treatment centers. All facilities, regardless of their designation, should be able to identify and isolate a patient with possible viral hemorrhagic fever, including Ebola. Identifying a person under investigation for Ebola, or a PUI, requires carefully evaluating 3 criteria. First, was the person in an Ebola-affected area within 21 days before symptom onset? A detailed travel history is needed to answer this question. Currently, the only affected areas are the 26 health zones within the North Kivu and Ituri provinces in eastern DRC. CDC keeps a map with Ebola-affected areas up to date on its website. Second, did the patient have direct contact within 21 days before the onset of symptoms with blood or body fluids of a person with EVD, objects contaminated with body fluids from a person with EVD, semen from a man who recovered from EVD, or bats or non-human primates. Third, does the patient have signs or symptoms consistent with Ebola virus disease? That's fever, headache, fatigue, muscle pain, vomiting, diarrhea, abdominal pain, or unexplained hemorrhage. If an Ebola PUI is identified, the two facilities will discuss patient transfer to the Ebola assessment facility. The core components for infection control are isolate the patient in a single room with a private bathroom, limit personnel who enter the room, use standard contact and droplet precautions. PPE type depends on whether the patient has diarrhea, vomiting, or hemorrhage and is clinically stable or not. Maintain a log of people entering the patient's room. Limit visitors. Establish procedures for monitoring and managing visitors. Please notify your local health department immediately if you have a PUI. There are a number of tools that have been developed for healthcare systems. I'd like to highlight a few for you. The CDC has developed 2 documents that might be helpful in creating order sets or standing orders. The first is guidance on assessing the risk of viral hemorrhagic fever, including Ebola, in a returning traveler. The second is assessing fever in a returning traveler if the risk of viral hemorrhagic fever is ruled out. One of the steps is to rule out malaria and other infectious diseases. During the 2014 to 16 Ebola outbreak, Virginia's local health departments monitored more than 2,200 travelers. 11 Ebola PUIs were tested at Virginia's public health lab. 4 of the 11 were found to have malaria. 2 others had Shigella and enteroinvasive E. coli. Malaria is the leading cause of travel-related hospitalizations and death. Early diagnosis and treatment are critical. In Virginia, an average of 61 malaria cases are imported annually from Africa. There is a rapid test available for malaria, which is very helpful in working up a PUI. Negative results must be confirmed by thin and thick smears. All cases of suspected malaria should have a parasitological test. The CDC has 24/7 resources in place to provide guidance to clinicians on the diagnosis and management of malaria. CDC recommends that healthcare facilities stay informed, ensure availability of appropriate PPE, review infection control policies for consistency with CDC guidance, review environmental cleaning procedures, and provide training for cleaning staff. Begin education and training for healthcare personnel. Review triage procedures. Ensure laboratories review their procedures for appropriate specimen collection and transport. Review policies and procedures for screening and work restrictions for exposed or ill healthcare personnel, and ensure they have ready access to medical consultation, including by phone. Designate points of contact responsible for communicating with the local health department. Some key take-home messages are that the risk of Ebola virus spreading within Eastern DRC and its neighboring countries is very high. The risk of Ebola virus spreading globally is low. However, U.S. healthcare facilities should be prepared to identify a person under investigation for Ebola, isolate him or her, and inform the local health department immediately. A detailed travel history is critical in identifying a PUI. Use the CDC outbreak map to identify where there are Ebola-affected areas. VDH has developed a new Ebola webpage, and CDC has a comprehensive set of resources online that they are currently reviewing and updating. Thank you.